I think a couple more people have joined, and then people can, well, probably filter in. So I'll just get started on the intro stuff at least, and talking about this paper. Um, I should probably introduce myself first. Sorry. I'm Nicole Gibbs. I am an ACVNU resident and clinical assistant professor at Tufts University for nephrology urology. Today, I'll be talking about long-term outcomes after infusion of EDTA and sub devices with benign ureteral obstructions. Okay, this paper is the first author is Berent, and so it is out of Animal Medical Center in New York, and it is just was published, I think, like a month ago on the Journal of Veterinary Internal Medicine. So for what we'll talk about today, I'll give a little bit of background on subs, but a little bit more on EDTA, the methodology of this paper, results, and then hopefully we can discuss some things that I think are always kind of questionable for subs or ways that I'd be curious to know how people manage these complications that they have in their practice, and then kind of a summary for them. So subs, or subcutaneous ureteral bypass devices, which I'll just from now on call them subs, is useful for ureteral obstructions, mainly in cats, although it has been reported in dogs. It can be helpful regardless of the underlying etiology or location of ureteral obstructions, and then comparatively to surgery or to stents, tends to have improved perioperative morbidity and mortality. They are also, because of how small the ureters are in cats, can be difficult to place ureteral stents in them, and as well because of where their ureter inserts into the urethra, kind of at the junction with the urethra, placement of a stent often causes dysuria. And so having a sub device that inserts into the apex instead can help reduce the dysuria comparatively to stents. There are many complications reported of subs, and these are just the kind of the most common ones that we see, although there are rare reports of others, but some would be chronic mineralization, which is reported previously to be about 24% of cases, the need for an exchange of either the nephrostomy tube or the cystostomy tube in about 13%, and then development of chronic infections in 8%. And then I didn't find a percentage, but there is a dysuria sometimes associated with the cystostomy tube in cats after placement of subs as well. Now I'll talk about a little bit about the tetra-EDTA solution that we talk about, or what is talked about in this paper for it. And so this is a chelating agent that complexes with cations, including calcium, but also magnesium. This is a highly water-soluble solution that it makes, and then it tends to have an alkaline pH of about 10.5 to 11.5 for them. This acts as not only a chelating agent and an anticoagulant, how we use it when we do blood work, but also as an antimicrobial and antibiofilm agent. And there's actually a ton of uses in human medicine that have been explored, some of which is consistently used in human medicine. So one that I thought was a little bit surprising was cosmetics and personal care products. So this moisturizer over to the right of the screen it contains EDTA, but it's disodium instead of tetrasodium EDTA for them. And this is what prevents interference of metal ions in water. I just thought it was kind of interesting that it's probably in our everyday lives. People use EDTA and we don't necessarily know it. The other way, kind of classically, is heavy metal toxicity, like lead toxicities in human medicine. And then it's actually been kind of more recently reported, or there was one study during COVID times that they actually used it as a locking solution in central venous catheters. And then the one that this paper talks about is urinary catheter incrustation and biofilm, but also wound management. This has been shown to be like an antimicrobial, can help break down some of the biofilms that can happen in the wounds for them. So for urinary catheter incrustation and biofilm, what's reported in humans for them has a little bit different of a blockage than what we actually think we see in veterinary medicine for the most part. So what causes the blockage in urinary catheters in humans is usually that they have long-standing Foley catheters in, and that Foley catheter, they get a urease-producing bacteria, mainly Proteus. However, there are other reports of other bacteria that are urease-producing that have caused this. They colonize the catheter, causing a biofilm, and then kind of similar to our struvite production for them, as the pH increases, calcium phosphate or apatate, whichever one wants to call it, or magnesium phosphate precipitates into the urine and also onto the catheter itself. And so this crystal deposit will also initiate stone formation, kind of acting as like a nidus, similar to like suture-induced stones that I think, or at least that's how I think about it for these, is that once they get a little crystal debris onto their nidus, kind of so they're more likely to form these mineralizations. And that once they form that, they have increased crystalline biofilm formation. And this is a picture that I pulled from this human paper in the Journal of Internal Medicine. And so this is the end of a catheter kind of cut for them so that you can see the holes. And you can see that there's all of this material, debris, crystalline material within the hole of the catheter. And then this is kind of a longitudinal, so they cut it kind of longitudinal instead of transverse for it. And you can see kind of covering most of it is this like plaque-like material. And they use an electron microscope to get kind of up close and personal with it, and can see some bacteria as well as all of this debris within the catheters themselves. Some of the reason they think they form in general, other than just the having bacteria, they do think that there's increased formation when there's irregular surfaces on the catheters. So kind of near the fenestrations that they will have that irregular surface is kind of what maybe where it starts, that they get this biofilm and mineralization. So it's a little bit different than in our sub cases, where we don't necessarily see them associated always with infection with the mineralization for them. And so it's less of like a magnesium and calcium deposits for them. And we think that it's mainly related to calcium mineralization in these guys. There has been 2 studies prior to the one that I'll talk about today that looked at tetraEDTA in sub-devices for mineralization. There's Duval et al. In 2022, that's in the Journal of Feline Medicine and Surgery. They used 4% EDTA for the most part and had a little bit of variation in their protocol for these. They used them in only obstructed cats, so if they had renal pelvic dilation or hydroureter, they would use them if the sub was in place and did not seem to be patent. They reported with their EDTA protocol that they had about 11 out of 16 of their cats had successful, where their success was defined as not or became patent again after using these EDTA protocols. However, about the half of the ones that became patent again after EDTA did have recurrence of their obstruction, with a median time to reobstruction of about 87 days. They did worry a little bit because in human medicine, EDTA can cause inflammation to the urinary bladder, because it was previously used to try and dissolve calcium oxalate stones, I believe. And so it's previously been infused into the bladder, and the reason they stopped doing that is both in rabbits and humans, it causes inflammation of the bladder wall. And so they wanted to look particularly, did EDTA have an association with dysuria? They did note about a little over half of their cats that had this EDTA protocol did have 1 or more episodes of plaquuria and or hematuria for them. A similar study, but this was more of a case series, and this one was out of AMC as well, JVIM 2019 paper that had 8 sub-devices that were obstructed that they did kind of a demineralization protocol using EDTA. This one had a higher success rate of 100% of them, but of course lower numbers of these patients overall comparatively. They did have a reobstruction rate of about 1/4 compared to about half of the other study that had reobstruction. And that obstruction occurred in about 2 of their 8 cats. So again, not high volumes in this one. for them. And then ultimately, even though it was unobstructed for them, they ultimately, one cat did need an exchange about 356 days after the first infusion. So it has been documented to be used in subs for mineralization, and I think anecdotally, a lot of people, including myself, use EDTA sub flushes kind of every 3 months initially for them as kind of the typical protocol that we use for them. So now I'll dive into this study. This study is looking at using EDTA and as kind of sub flushes more regularly to see did it have a difference compared to saline flushes. And their hypothesis was that EDTA sub flushes will have less mineralization and less chronic infection than compared to saline flushes. So for their methodology, for their cases, it was dates from January 2012 to July of 2020. The inclusion criteria was cats undergoing subplacement for benign ureteral obstruction. They had to have had pre-op diagnostic imaging as well as biochemistry panel and a completed surgery report, so they can know exactly where the sub was placed and was it in ureter, was it in renal pelvis. In addition, they had to have follow-up of at least 180 days for each cat to look at mineralization and urinary tract infections in these. Exclusion criteria was if there was less than 180 days of follow-up, or if between sub flushes more than 180 days lapse between them for the follow-up period. So they didn't, basically excluding any cat that wasn't routinely coming in for their sub flushes and kind of missed a couple of their sub flushes, since those would maybe impair our ability to make any conclusions from the data. They did, though, as for the less than 180 days follow-up, if a cat did develop mineralization or an infection during that 180 days, they were included in the follow-up time, even if they did not have follow-up data past the 180 days. So they did some nice definitions in their methodology as far as what they considered for each kind of variable that they were looking at. So for urinary tract infection, or UTI, they had to have a positive urine culture with associated pyuria and clinical signs. And clinical signs that could be indicative of the UTI for them was dysuria, lethargy, hyporexia, change in behavior, and progressive anemia, or sorry, azotemia for them. They called asymptomatic bacteria if there was a positive urine culture but no clinical signs. And then a chronic UTI was defined as greater than 2 urinary tract infection episodes within 12 months, or greater than or equal to 2 episodes in 6 months. They define clearing a urinary tract infection as having a negative urine culture while not receiving treatment without recurrence for more than 6 months. So they had to be cleared of their infection for at least 6 months to be called cleared. For mineralization, their definition was if they saw ultrasonographic shadowing debris on the catheter while they were flushing. In addition, there was any delay in the visualization of turbulence during subflush, even if the catheter was, or the tube was patent overall. So they did have to exclude other causes of poor flushing, such as a kink in the system, especially important for the 2.0 systems that they used, blood clots, or purulent debris for them. A complete obstruction was defined as one or more catheters that were unable to be flushed, and then exchange was recommended if occlusion of any part of the device had also renal pelvis and ureteral dilation to support a recurrent obstruction. But in some of the cats, as has been reported previously, they can get their ureter can become patent after sub placement, and so then they don't necessarily need replacement or exchange if their sub's not functional. So they didn't do those unless there was actual evidence of an obstruction in the renal pelvis or ureter. They had 3 different groups for them. So group 1 was that their sub device was flushed only with sterile saline. So no EDTA in this group. And this was an earlier protocol. So it was from April of 2012 to April of 2017. And then after April of 2017, they switched to doing EDTA flushes. And so, but there was some group that was kind of between those groups. And so that's called group 2, is where they were flushed initially with sterile saline, but then switched to EDTA for the routine sub-flushes. And that, again, was 2012 to 2017. But then group 3 is the newest group because they changed protocols as they were seeing these cases more and decided to use tetra-EDTA. And so that data was collected between 2017 and 2021. There was, for the group 3 devices, that's also when, notably when the 3.0 sub came out comparatively to the 2.0 sub. So there were, group 3 is kind of a heterogeneous group in that it has some of the sub 2.0s, or a majority is sub 2.0 devices. For the sub-flush, it was done in a routine manner, as had been previously described. They determined the flush interval to be the average number of days between sub-flushes for each device. And then ultrasonographic evaluation needed to see renal pelvis and ureteral diameter, the lumen of the urinary bladder, entry of the cystotomy catheter, and then assess the catheter tubing for any shadowing or mineralization. They then would infuse saline in 0.25 to 0.5 ml increments and then removed that after each infusion for them. In group 1 and the first part of group 2, they would do that only with saline and then would be done. Versus with the group 3 and part of the group 2, they would infuse 2 mils of 2% tetra-EDTA for them at 0.25 ml increments. They would do sub-flushes prior to discharge, but after the procedure, then at 1 month, then every 3 months for 2 years, and then every 6 months after that. For statistics, they did an ANOVA to evaluate mean differences, as well as ordinary least squares regression analysis for continuous response variables. For discrete response variables, they did logistic regression, and then they did Pearson's chi-square or Fisher's exact test to evaluate frequency analyses for them. So onto the results. So this is kind of the first table on it, just looking at how many cats were in each group, whether it was unilateral or bilateral. There was overall 95 devices in 66 cats that met inclusion criteria. The age was significantly different between group 1 and 3 and between group 1 and 2, with group 1 having the older cats. There was, though, despite them being older cats for them, there was overall similar follow-up between the two, which is in this last column here, and there was no difference in follow-up time for them. And as they note, about 17 cats had the sub 2.0 in group 3, and 16 cats had sub 3.0. So for the results, for them, there was no difference they looked at calcium or creatinine, and there was no difference in the preoperative calcium or creatinine. There was no difference in groups between UTI at time of surgery between the groups. And then the renal pelvic diameter was different between group 2 and 3, but not different between group 1 and 3 and the other ones. Cause of obstruction, again, no difference between groups, so all the groups were fairly similar when you look at them across the board, other than the age. So a little bit older in group 1, but otherwise there wasn't that many differences between the two groups for variables that they weren't looking for. The majority, similar to what has previously been described, was ureteral lithiasis as the underlying cause for obstruction, occurring about 78% of those. And then stricture was the second most at 22%, and then pyelonephrosis was not very common at 6%. Comparatively, so I said some of them had 2.0 and some of them had 3.0. So overall, 83% of the cats had 2.0 and 17 had 3.0, with all of the sub 3.0s being in group 3. And then they did note that 5 of the cats had post-op urinary catheter, which is no longer done typically for them, so none of the rest of the groups had any. For follow-up, as I mentioned, similar follow-up times between each. All of the ones in group 1 and group 2 had a median survival time, so all were dead by the time this manuscript was written. The median follow-up time in group 3 was over 1,000 days, with 55% being alive. So even though it might have caused some problems if group 3 had a shorter follow time and less mineralization. That's not the case because it actually has longer follow-up, so it wasn't a lack of follow-up time for why they had their results. For post-procedural creatinine, they were all the same until, or all similar until month 12, where group 1 and group 3 did have a difference in their mean creatinine after 12 months for them. When they looked at kind of the variables they were wanted to look at, which is mineralization and UTI, as some of their main criteria they wanted to look at in this study for EDTA, because that's what they were hoping to prevent against by giving routine EDTA flushes. They looked at mineralization. So again, that's when they either saw it ultrasonographically or they noticed a delay in seeing turbulence in the renal pelvis or into the cystostomy tube. For them, there was no difference between group 1, which was saline, and group 3, which was the EDTA group. There was, interestingly, a difference between group 2, which had the saline and the EDTA, and group 3, which was just the EDTA. For them, they also did not have a difference. There was no difference between groups in the actual percentage of occlusion. However, if you look, even though it's not statistically significant, I do think kind of the percentage-wise, looking at them, about half of them had occlusion comparatively to this group, where about 29% and 38% had them. So it seems a lower percentage and may clinically impact our decisions, even though statistically not significant for them. And then the rate of exchange was also similar between groups for them, with only group 2 and group 3 being different from each other. The rest were all similar and not considered statistically different. But again, looking at percentage-wise, exchange for group 1 was 14% versus 6% in group 3. So if there's more cats or something like that, maybe there would be a difference. This is again looking at occlusion for them, but looking more at the days between when occlusion occurred for each of these groups. So there was no difference in time between when these devices would occlude between group 1, which was the saline group, and group 3, which is the EDTA group, and no difference with group 2 as well. There was also no difference when they looked at the etiology between why they obstructed, so ureteral lithiasis versus stricture. There was no difference in what caused the obstruction for their time to re-occlude their device either. And there was no difference in postoperative hypercalcemia and mineralization. However, it did start to approach significance. Oh, sorry, that's my next slide. So for the mineralization, they did look at hypercalcemia long-term and mineralization and need for sub-exchange and tried to see if that was statistically significant. And it seemed to approach significance for them. There was not that many cats in the study that had a hypercalcemia. So there was 3 in group 1, 2 in group 2, and 5 cats with hypercalcemia in group 3. So there really was only 10 cats total in this study that had hypercalcemia for them. So I think it's a little difficult to draw major conclusions from that, but it did not seem at least statistically significant for them. In addition, there was not always follow-up ionized calcium levels available for all cats, unfortunately. All right, so other than occlusion and need for exchange and mineralization, they wanted to look at the rates of infection for EDTA. For them, notably, EDTA did not cause any dysuria in cats after sub-flush for them. So as I mentioned in kind of the background, that is something that they can see when EDTA was directly infused into the bladder of humans and rabbits, that they would get a lot of inflammation. That does not seem to be the case with the 2 milliliters of the 2% tetra EDTA used in the sub-flush. They did find that UTA at the time of surgery was associated with development of chronic infection, which has been previously described in other studies. And there was no difference in time to first UTI between the groups for them. What was different, and kind of, I thought, a pretty interesting result for them, is that there was no difference in whether any bacteriuria occurred, so whether subclinical versus urinary tract infection for them. There was no difference with similar percentages between the 3 groups, but there was a difference in group 2 and group 3 or group 3 compared to group 1 in how many chronic infections they had for them, with group 3, the tetra-EDTA group, having significantly less chronic urinary tract infections, which I think overall is fairly interesting since the bacteriuria was not really different between any of the groups. In addition to having less chronic UTIs in the tetra-EDTA group, there was also less or more cleared infections in the tetra-EDTA group compared to saline for them. And so EDTA could potentially reduce chronic urinary tract infections in subpatients as well as increase the ability to clear the infection for them. So discussion-wise, I think limitations, at least in my thoughts for this study, was I think, unfortunately, and I think this is just natural with how the devices have progressed, so I don't think there's anything they could do differently about this one other than, it had different time periods. So the saline flushes were kind of earlier in the process of placement of subs, and then EDTA was kind of a different subset of cats that were later on in when they've been placing these subs. So that could potentially lead to some of the differences, such as the chronic UTIs for them. In addition, they did have 2.0 and 3.0 devices, which they compared and did not see a difference between the two of them. And this study wasn't looking at whether 2.0 or 3.0 was better for them. But I do think having those two devices included in the study just does add a different variable to it. Additionally, the mineralization, when I read the paper, I was a little bit unclear exactly what their measurement in the delay of turbulence was. So it was unclear to me how they defined that and whether it seemed to be a more subjective measurement. However, they do, I'm sure, many of these, and so they can probably get a feel for whether it's more turbulent. I think having a more objective measurement may have been helpful for them. In addition, it was difficult, it may be difficult to see ultrasonographic shadowing debris if the catheter was placed into the ureter as opposed to the renal pelvis for them. And then unclear what the standard procedure was, if there was delay in visualization of turbulence. Did they always do radiographs to rule out a kink in those cases, or did they always was there a certain thing that they did if they did see the delay in visualization? It just wasn't clearly stated in the study for that for them. And then I think one other thing would just be that of the tubes they exchanged, I think it'd be interesting to look at what actually is causing the obstruction potentially, if we could see it in the cystostomy or the nephrostomy tube, to see exactly what is this mineralization that we're seeing there, because we assume it's calcium based just given the cats themselves, but it would just be kind of an interesting thing to look at for them. So we don't actually know, was the mineralization the cause of the obstruction? It makes the most sense that it was. And then key points that I took away from the study was the use of EDTA is probably helpful and not, at least not harmful. So I think your success, especially because a lot of clients put a lot of money and time into placement of subs. And so I think trying to keep them patent and the kidneys as happy as possible and save the nephrons that we can, trying to decrease the submineralization rates is really important for us. So I think EDTA may decrease it. It wasn't statistically significant, but I think when I think of clinical significance for this, I do think those percentages, even if it is a slight drop in percentage, is something that I would try to do to try and save these devices, just given kind of everything these cats have already. It did show to decrease post-operative chronic UTIs, as well as their ability to increase their ability to clear them in the EDTA group. So I do think that's an important thing. One thing I didn't mention in the limitations, though, is that I think the definition of UTI has changed in the last 10 years, where we now have increasing recognition of subclinical bacteriuria. So I think that's just something to keep in mind when we talk about urinary tract infections. And it didn't cause a change in time to mineralize, so it didn't delay the onset of mineralization, which is a bit interesting for them. But again, I think unlikely to be harmful. They didn't note any dysuria afterwards. And then there was no association with the hypercalcemia and mineralization or need for sub-exchange. but it did approach significant, and it was such limited numbers that I do think we need to take the hypercalcemia and treat it maybe more aggressively in the subs to prevent mineralization, or follow-up studies should be done for them. And I think just knowing that cats with UTIs at the time of sub placement are more likely to have chronic UTIs is just important when we're considering placement in those for them, and what the best steps are. So overall, I thought this was a really interesting study. I thought it had some really great takeaways. I don't know what everyone else's thoughts, or if anyone has any other comments. I think I would love to hear what people are doing. And if they do have a case that obstructs, how often, like, and the calcium's controlled, do you have those cats come in for more frequent intervals with EDTA? How often do you add potassium citrate, hydrochlorothiazide? People give alendronate even if the calcium's normal for them. Has anyone used anything else for subflushes other than EDTA and saline? And then if anyone has any thoughts on why some cats, I feel like we all have those cats that they obstruct like 3 subs and you don't know why for them, and why that cat does it. So, and then just a couple other discussion points if anyone has any thoughts. I think Marilyn Dunn, if you want to say your comment.
Hello, that was really well done, and you've asked so many questions. I think it could be like a 3-hour discussion. So I guess I can just I can give you my thoughts. It's very interesting, and we're actually doing a study that's similar, because in Canada we're actually not allowed using 2% EDTA. It's kind of a copyright thing. Not copyright, but whatever, trademark, I should say. And so we're using 4%. So we're kind of doing a very similar study that was that you presented. We have results that are kind of similar. We'll be presenting them at ACVIM. So we're just kind of finalizing a few things. So stay tuned for that. I guess some of the questions, and just kind of thinking out loud is, when you're in, especially with the 2.0s, what you're flushing, we're calling it a locking, and people, they call it a locking solution because they'll finish the flush and they'll lock it, meaning that the solution stays within the catheter. But that's not really happening with our sub 2.0s, right? When you're flushing, we're saying we're using it as a locking solution, but it really doesn't stay very long, and it'll follow the path of least resistance. So if you already have like a partially mineralized nephrostomy catheter, then it probably won't head up much in the nephrostomy. It'll probably just go out into the bladder, and then the cat's going to pee it out probably pretty quickly. When you're using the sub 3.0 and you're flushing, then that's probably a little bit more it's kind of more of a locking, because it'll stay in the kind of accessory tubing, because there's no actual urine flow through that. But then once it kind of hits your Y or X piece, then it's probably just going into the bladder, or if you flush it pretty hard, it's going up into the kidney. So I'm always kind of amazed that there would be an effect for something that's, and I mean, usually your 3.0, your accessory catheter doesn't block. It's the nephrostomy or the cystostomy catheters that mineralize. So I don't know. I'm just kind of thinking out loud. I'm kind of, when we're using EDTA, and I think there's been a couple of studies that have shown that when you have mineralization, you're doing more intensive protocols, large volumes, and you're doing it a number of days in a row, then you're going to get some kind of effect from the EDTA, and you can get dissolution in the majority. They can reobstruct afterwards. But just using it as a flushing solution, I'm kind of amazed that it would have an effect. And when you look at the mineralization, there was a tendency towards, for the chronic infections, when you break down the numbers, as you said, it is still small numbers. So I don't know, I guess, yes, it was statistically significant, but if they had 2 patients less, it wouldn't have been. So it's always hard. So I think that the study's interesting, and they did the best they could with the numbers, and they have more numbers than most people. So it's still fantastic, but it's still a small number. And we had that in ours. Like sometimes we made a mistake. There's 1 patient, and now suddenly mineralization is significant. So I think you have to be really careful when you're talking about 4 patients. So I don't know. I guess I kind of argue, does it really have an effect the way we're using it? And I guess the other bigger question, which this article didn't address, but it addresses maybe some of the points that you raised, is flushing necessary? People spend all this money and they're very concerned about obstruction, but does flushing do anything? Does it change the infection rate? Does it change the bacteria? If it does, we probably don't really care. Maybe it's more the infection that we're concerned about and mineralization, but does it actually change anything? And it hasn't been published yet, but there was an interesting abstract that was done in Europe by a French group that showed that, and they didn't flush with EDTA, is either those that came back for flushing were flushed with saline, those that weren't able to come back for flushing, just weren't flushed. And when they followed them up, they had pretty much the same rates of chronic infection and mineralization. So I think that comes back to the basis is that it'd be really interesting to do a study and see does flushing make a difference or not? Are there certain patients that should be flushed? And I think we've all had, and you mentioned that too, that cat that if it goes 6 weeks without being flushed, it blocks partially. We've got to do an EDTA protocol. And if it comes back every month, then it doesn't obstruct. So maybe there's specific patients that would benefit from more intensive flushing or flushing with EDTA, but maybe that's not representative of the general population. So I don't know, I've gone on way too long, so I'll let other people comment. And I probably only responded to about 1/5 of the questions you raised that are all really important, pertinent questions. And it's obvious that you have a lot of experience with subs because it's all the sorts of things that we discuss on a daily basis that we don't necessarily have answers to. But I think it raises a lot of questions, and hopefully there'll be other, maybe studies in the future that'll help us answer some of those a little bit better. But sorry, last thing I wanted to mention too, is that really good question about what do you do when they mineralize and their ionized calcium's controlled and everything else looks good and they're just mineralizing like crazy and they're already on potassium citrate. I don't like using hydrochlorothiazide in chronic kidney disease patients. It just worries me a bit. I have done calcium to creatinine ratios in their urine. And I've kind of based it on like a 0.03 ratio. I think that's looked at in cats with upper urinary tract mineralization. And if it's high, then I will put them on alendronate. And even if it's not high sometimes and they're just mineralizing like crazy, even if they're not, even if they don't have a serum hypercalcemia, I've put them on alendronate. But I can't say that it's helping them not mineralize their subs or not. But I definitely feel that there's this specific population of cats, specific ones that will just like keep mineralizing their subs, and you change them and you try everything and they don't work. But yes, I have been using alendronate in some of those exceptional cases. Maybe that's working. Again, it's 3 or 4, so I can't really comment on that.
Great. Thank you so much. I love like comments and getting to know what you do for some of these challenging ones for sure. And I agree. I think we see some that don't ever like come in 2 years later, never been flushed, and they're super like they're patent, everything's fine, and the ones that come in to flush, and I think we really don't know the different populations that need it.
We tend to be pretty aggressive with our citrate, so potassium citrate, or using Moonstone, which is a blend of different citrates. We have, so I'm in the Front Ranges in Colorado, and we have a population of cats from kind of the South Denver, Colorado Springs area where we think it's probably water quality related. The water's really hard, but we see those cats really form mineral very quickly if we're not really aggressive. So we tend to favor urinary diets versus renal diets as long as their kidney function's okay, and using kind of diets that have, a low calcium, but then also the low calcium phosphorus ratio, kind of based on Val Parker's studies of dietary management for hypercalcemic cats. And then we're pretty aggressive with our citrate supplementation, because I do think, a bit of a black hole for our knowledge of stone prevention is kind of the role of inhibitors, given that it's not very easy for us to measure them. But that's, I think with us being more aggressive, I think we are seeing the cases that we've done more recently that we are a lot more aggressive right from the get-go. We are seeing better outcomes.
Great, thank you. What was the name of the other citrate that you use?
It is the trade name is Moonstone. It's a blend of potassium citrate, magnesium citrate, and sodium citrate. It comes as capsules. Each capsule is, I think, 2.5 milliequivalents of citrate. So I used to use it as an add-on for patients that kind of weren't tolerating the amount of potassium I wanted to, they were getting with the citrate, or the occasional patient that would get GI upset with potassium citrate. But I've actually we've started using it up front earlier. And I guess particularly for calcium oxalate patients, magnesium potentially is inhibitor, will bind with oxalate. So maybe there's also some additional benefit compared with compared with potassium citrate. I don't know if Jodie's got any, or Larry have got any thoughts about that, but we've started using it in a lot of our cases right from the start, either instead of or in conjunction with potassium citrate.
Great. Thank you. That's really helpful to know of like other options that we could use for them.
Well, it worked quite well because, you know, for some of those patients that don't want to eat the tablets, the stone stopper capsules are quite big, but you can open the capsules and mix it with cat. So I've got quite a few cat owners that's how they administer it, and they actually find that a lot easier to administer sometimes than trying to pill them with potassium citrate.
Yeah, great. That is nice that it comes as a capsule.
I have not used a lot of potassium citrate, but I think it's worth thinking about. You know, in humans, there is a specific population, and Dr. Furrow talked about that in the core curriculum, that are hypocitrate uric. I don't know the data in cats at all, but it would be interesting to try some of these cats that are very prone to re-encrusting their subs quickly. And then we've got one we're managing right now with about every 4 to 6 week flushes because he encrusted his first 2 subs so fast.
Yes, we also had one that was on its 4th sub, and so that one's now on potassium citrate, and I think we might have done hydrochlorothiazide on it, and then are flushing it very frequently. I don't know how frequently now, but it obstructed on once a month flushing. So I think in those cases, they always make me wonder like how much I'm doing with the flushing versus not, but also want to try and keep it as patent if we can. Yeah. Does anyone else have any other thoughts or questions or things about the study or anything else sub-related? Well, thank you all for joining and for your input on this and the study and sub-management in general. I really appreciate it. It's always so interesting to kind of know what everyone else is doing in challenging cases or in general. So, well, thank you guys.
Thank you so much.
Thank you.